This educational video is designed to provide information on the specifics of the Iowa Newborn Screening Program. Topics that will be covered include the Iowa Department of Public Health's newborn screening programs, how to perform newborn screenings, conditions included on the Iowa Screening Panel, newborn screening is a screening tool and not a diagnostic test, refusal and retention policies, and additional resources.
Newborn screening is a series of tests that can detect life-threatening or life-altering conditions that, if we find them soon enough, we have a chance to intervene and make a positive change in that baby's life.
The Iowa Department of Public Health is required by law to provide 3 newborn screening programs. We have the blood spot screening program, which is also known as the Iowa Newborn Screening Program. We have the hearing screening program for newborns, which is called the Early Hearing Detection and Intervention Program, or EHDI, E-H-D-I. And then we also screen newborns for critical congenital heart disease, or CCHD. The Iowa Newborn Screening Program, or the blood spot screening program, is supported almost entirely by screening fees charged to the patient. And what usually happens is that the hospital will pay the fee to the state hygienic screening laboratory, and then the hospital turns around and charges the patient's insurance company or the patient directly for that. And these fees cover the laboratory testing, follow-up on any abnormal results. It pays for a courier service that goes and collects the specimens at all of the hospitals or provider practices and sends them to the state hygienic laboratory on a daily basis. It also covers administrative costs for the newborn screening program, the work that I do at the health department, and it also covers any educational initiatives, any awareness program that we need to do to make the system work.
The screening process checks for endocrine, genetic, blood, and metabolic disorders. Newborn screening involves a team process that includes blood collection, lab testing, follow-up, and clinical management. This training video focuses on the collection of blood specimens.
Gently putting pressure and then...
The collection process includes 5 steps: educating parents about newborn screening, filling out the demographic information, collecting blood specimens with a heel stick, submitting specimens for testing, and tracking newborn screening results. It's important that we as medical practitioners collect good blood samples and promptly send them to labs for testing. This video will show you how.
The law requires that healthcare providers and birthing hospitals provide education to parents about the newborn screening process, and again, I'm speaking specifically about the blood spot screening process, prior to collecting the blood for the screening test. Ideally, this would happen during the prenatal care period. That will allow the parents to look at the information on their own time. They'll have more time to review the information, to develop an understanding about what the process entails, and then we'll give them time to ask questions, and they can certainly call us for those questions.
The State Hygienic Laboratory at the University of Iowa provides newborn screening forms for the collection of dried blood spot newborn screens. It is vital that the demographic information be filled out completely and accurately. Please do not assume contact information is up to date. Review the demographic information with the legally authorized representative to ensure the newborn screening program can locate the infant and his or her primary care provider in the event that there is a time-critical result. When to collect the newborn screen. Newborn screens should be collected on all babies once they reach 24 hours of life. There are a few instances where the newborn screen should be collected early. If infant requires a blood product before 24 hours of life, if infant is being discharged or transferred out of the birth facility before 24 hours of life, or if infant is not expected to survive to 24 hours of life.
When collecting the blood specimen, first talk to the parent or guardian to make sure the information on the form is correct and complete.
Well, my name is...
Be sure to fill in all fields and confirm the baby's first and last names, address, birth date, the mother's full name and birth date, and the date of collection. Missing information is one of the major errors made when submitting screening forms. It is good practice to have a second person check the kit for any errors or omissions. A second set of eyes can avoid these common preventable errors. Once you feel certain about the accuracy and completeness of the form, talk to the parent about where and how you will collect the baby's blood. You will use a heel stick method and collect from either side of the baby's heel. Look at the diagram showing where to prick the heel. It may help to warm the baby's foot and place it lower than the baby's head to use gravity to improve the flow of blood. If the mother is present, she can choose to breastfeed the baby to help with the child's discomfort. Gently rubbing the baby's leg before performing the heel stick may also help control pain. Before pricking the child's heel, wipe the area with alcohol and allow it to dry to make sure there's no excess moisture. Now hold the baby's heel firmly with one hand, ideally your less dominant hand, and use the other hand to hold the collection paper. Remember to avoid touching the filter paper when handling the collection kit. Touching the filter paper with ungloved hands can contaminate the specimen area. Now carefully, quickly, and thoroughly saturate the circles on the collection kit with blood, filling each circle completely before moving to the next. Make sure the blood soaks completely through the filter paper and avoid letting the paper contact your hands or the baby's foot. Put the collection form on a flat surface or a horizontal drying rack for 2 to 4 hours.
Keeping the specimens in a horizontal position while they're drying is important, so the blood will dry uniformly, and also it gets them up off of the bench top so that they won't get contaminated with anything.
Specimens must arrive at the state hygienic laboratory within 24 hours of collection.
The newborn screening specimens get to our laboratory, our branch laboratory in Ankeny, by using a courier, Central Delivery Services of Iowa, that operate 365 days a year. So specimens are picked up every day from the hospitals. They're delivered to our laboratory where testing can immediately begin 365 days a year as well. The majority of the testing is carried out at night by our night shift. After the courier has picked up the specimens in the late afternoon, they deliver those to the laboratory in Ankeny around 9:30, and our staff immediately begin testing those specimens at that time.
As abnormal newborn screen results become available, they are reported by laboratory staff to the newborn screening follow-up team. The newborn screening program will contact the infant's primary care provider and inform him or her of the abnormal result. The program staff will provide recommendations on the appropriate diagnostic testing based on the specific abnormalities detected. Education will be provided on the disorder, as well as any medical care the infant will need while he or she undergoes the diagnostic workup.
The Iowa Newborn Screening Panel, or the list of conditions that is screened for by Iowa, covered by the blood spot screening, that's determined by a process that provides for an expert review of the evidence pertaining that condition by a subcommittee of the Congenital and Inherited Disorders Advisory Committee. We call that CYSTIC. CYSTIC has a subcommittee that is charged with management of the newborn screening panel, and that includes the addition of new conditions or even removing a condition from the panel if it's no longer appropriate to have screening done for that.
The Iowa Newborn Screen can detect over 50 treatable conditions where early intervention is critical. The Iowa Newborn Screening Panel includes congenital adrenal hyperplasia, congenital hypothyroidism, hemoglobinopathies such as sickle cell disease, cystic fibrosis, galactosemia, biotinidase deficiency, amino acid disorders such as phenylketonuria, fatty acid oxidation disorders such as MCAD, organic acid disorders such as isovaleric acidemia, and severe combined immunodeficiency or SCID.
Some of our disorders are more time critical than others. The newborn screening program carefully divides our disorders by level of urgency. Therefore, when the newborn screening program contacts you outside of normal working hours, this means that the condition is in fact emergent and time sensitive.
We screen for 2 endocrine disorders in babies. One is congenital hypothyroidism, and the other is called congenital adrenal hyperplasia. So for congenital hypothyroidism, it's important for us to identify a baby that has this condition early. The reason is that early treatment can help the baby's brain develop normally. If we don't treat a baby that has congenital hypothyroidism, the baby will end up with the brain not developing well at all and the baby losing intelligence. So this is why it's very important to treat that disorder as early as we can. In the state of Iowa, we screen for congenital hypothyroidism also through the newborn blood spot program, and the level of a hormone the body makes called TSH is measured. When the body's thyroid does not work well, the TSH level tends to become elevated. And so through the screening process, we're able to identify which babies have an elevated level of TSH for additional testing. When we find a baby has an elevated TSH, this indicates that they may have congenital hypothyroidism. And again, the information of the elevated TSH will be relayed to one of the endocrine pediatricians here at the University of Iowa. And we will then call the baby's physician of record and discuss the next steps. If the TSH is extremely high, we like to have that baby on the same day be seen by their doctor and to have a confirmatory blood test drawn to check and see that the TSH really is very elevated, and to go ahead and start the medicine to treat congenital hypothyroidism, which is a medicine, it's just a pill you take once a day called levothyroxine. For congenital adrenal hyperplasia, this disorder is lethal if we don't treat, so usually a baby will die at about age 10 or so, 10 days, if the baby's not treated. So it's very important to treat these babies to identify them as quickly as possible to prevent death. And that blood spot is tested for the level of a chemical that the body makes called 17-hydroxyprogesterone. When that level is high, that indicates there's a possibility that the baby has this condition called congenital adrenal hyperplasia. CAH is what we like to call this disorder. And that then tells us that additional testing is needed for that baby to determine if the baby actually has the condition or not. Yeah, so after we find a baby that has an elevated 17-hydroxyprogesterone, meaning that the test indicates that they might have CAH, the next steps usually involve another blood test to check the actual level of 17-hydroxyprogesterone and to follow the baby's electrolytes. Because these are what become abnormal as the baby becomes sicker and sicker with CAH.
The Iowa Newborn Screening Panel contains more than 50 disorders. The majority of these disorders are metabolic disorders, which are my specialty. It's important to realize that we have both primary and secondary targets for newborn screening. Newborn screening is designed to capture a certain group of disorders, which we refer to as our primary targets. Because of the nature of the testing, we can also pick up a subgroup of related disorders that are considered secondary targets. This means that the screen is designed to pick up a disorder, but a similar disorder may be picked up as well because the test results can reveal it. We separate our newborn screening metabolic disorders into 4 main categories. Number 1, aminoacidemias and urea cycle disorders. Our aminoacidemias and urea cycle disorders are actually a group of disorders that cause abnormal elevations or lowering of amino acid levels in the blood, and that's how they're detected. All dietary proteins are made up of strings of amino acids, like pearls on a string. When you go to use protein for energy, you have to break it down to the individual amino acids. And then you have to break the amino acid down into CoAs in order to use it to make energy in the mitochondria. Our amino acid disorders are primarily caused by inability to perform these processes. Unfortunately, sometimes these amino acids that are naturally occurring parts of every dietary protein are toxic if levels are allowed to accumulate high enough. A good example is phenylketonuria, where phenylalanine, naturally occurring amino acid found in every dietary protein, causes nerve damage and brain damage, and if allowed to continue to accumulate over time, causes permanent mental retardation. Number 2, organic acidemias. Organic acidemias are a group of toxicity disorders where individuals generate abnormal acids in their body. These disorders can be extremely serious and cause very quick decompensations. Most of these disorders are extremely rare and will not be familiar to providers. Our third category of metabolic disorders that are picked up on newborn screening are the fatty acid oxidation disorders. These disorders involve an inability to properly use fats for energy. Instead of being able to use fats for energy, people with these disorders generate abnormal metabolic compounds that can be toxic and cause decompensations, including heart failure, muscle breakdown, and sudden cardiac death. One example disorder for the acute presentation is MCAD. Babies with MCAD are completely normal. They are chubby, and they're happy, and they eat normally, and they're very interactive. But if the baby becomes ill or goes too long without eating, and we don't know the baby has MCAD, they can present with sudden cardiac death. The single most common presentation for MCAD prior to newborn screening was either severe liver failure and collapse or SIDS. And number 4, other. Include biotinidase deficiency and classic galactosemia. Our other category has disorders that would probably fit into the first 3 categories, except that the testing method used is different. That's why they get separated out. Metabolic newborn screening in Iowa is done on a blood spot specimen. The paper is then transported quickly to the newborn screening lab, where tandem mass spectrometry is done on the sample to analyze for abnormal metabolic byproducts that are markers for metabolic disease.
So the role of newborn hemoglobinopathy screening program is to identify newborns with various hemoglobin disorders. The focus is to diagnose babies with sickle cell disease or other variant hemoglobinopathies. Newborn screening program in the state of Iowa is really cutting edge and uses the HPLC technology to identify abnormal hemoglobin. Newborn screening program has saved many lives with children with sickle cell disease. Once the newborn is detected with abnormal hemoglobins, results are communicated to the patient's pediatrician and their family. We actually have a dedicated genetic counselor who provides the guidance about inheritance pattern and risk for the subsequent pregnancy. Identification of these babies has really transformed the care of particularly sickle cell disease babies. Because they are at increased risk of infections like pneumococcal infections in their infancy. And so early initiation of penicillin prophylaxis has saved many lives. And so I think that's really the important achievement of newborn screening program for hemoglobinopathy.
Cystic fibrosis is included in the Iowa newborn screening panel because it is a treatable genetic disease that can be detected, and treatments make a difference, especially if you start them early on. One of the reasons why intervention is so important in cystic fibrosis is if you don't intervene early, the outcomes of the patients, especially with growth, but with other things as well, never is as good as if you treated the patient starting from right as close to birth as you can get. The testing process for cystic fibrosis newborn screening is a 2-step process. These are done off the newborn screen blood spots. The first part of the test is an immunoreactive trypsinogen, or IRT, which is elevated in all patients with CF, or virtually all patients with CF, and many patients that don't have CF, including carriers. So if that's positive, then we move on to doing a genetic test, which is the way that most of the states are doing that test. So they have an IRT followed by a genetic test. They, of course, look for the most common mutations we see in CF. We're also the newborn screening center for the Dakotas as well, and they have some specific populations, and we're revising our newborn screen to make it so it catches their specific mutations, which are less common. So what happens after the newborn screen identifies a patient that's at risk for cystic fibrosis is the newborn screen program contacts the local physician that is taking care of the patient or is scheduled to take care of the patient, and then they contact the family to let them know about the newborn screen. What they then do is go to one of the nearby cystic fibrosis centers, of which there's Omaha, Des Moines, and Iowa City are the main centers for our areas. There's also Sioux Falls for South Dakota. And then they usually get a sweat chloride test to confirm whether or not they have cystic fibrosis. The newborn screen is a screen, and it's not a diagnostic test. So even if you presumptively have a positive by the genetics even, you need to get a confirmatory test. So one of the things that we have found with doing CF newborn screening is that carriers are most of the time picked up with the newborn screening process. The immunoreactive trypsinogen or IRT test will oftentimes be high in patients, so then we'll go on and get the genetic test and we'll find that they have one of the common mutations, so we'll pick up a number of carriers. It's not an absolute test for if you're a carrier or not. You certainly can be a carrier but not have a newborn screen test that is positive, but the majority of the patients with that are carriers will get caught by this method as well. So newborn screening is important to me because I take care of many patients with cystic fibrosis, and I strongly believe that if we start very early and as early as possible within the first month, we can make a big difference in their outcomes, especially with nutrition and growth, and eventually with their lung health as well, which are the main things that they struggle with CF.
The Iowa Newborn Screening Panel includes a screen for an immunologic disorder, which is actually a syndrome called SCID, or severe combined immune deficiency. The assay that's done to screen for SCID is actually a quantitative PCR, polymerase chain reaction mechanism. It is a very sensitive and specific test that's done to detect and actually amplify TREX, or T-cell receptor excision circles. T-cell receptor excision circle is a very robust marker of the development of functioning T cells within the thymus. So when this PCR assay is run on a dried blood spot of a SCID baby, you pick up very, very low, or in fact sometimes absent, numbers of these T-cell receptor excision circles. Here in the state of Iowa, if we identify a baby who has an abnormal SCID newborn screen, the primary care provider is then asked to contact the parents and arrange to get the baby second-tier testing called flow cytometry, which actually determines the absolute numbers and relative percentages of lymphocyte subsets. That test is really important and enables me to know if this baby has relatively normal T-cell numbers or not. Babies born with SCID look completely normal at the time of birth. So a parent, a primary care provider, isn't going to pick up any clues on the physical exam that this baby has a profound deficit in the immune system and is thus at risk for severe and potentially life-threatening infections. So with newborn screening, we can pick up these babies before they have their first life-threatening infection, before they develop end organ damage from that severe damaging pneumonia, that episode of sepsis or meningitis. And that is critical.
Yeah, so when you think about the newborn screen, it's important to realize that first of all, it is a screening test, and so it is not tuned and actually can't be tuned to have perfect sensitivity and perfect specificity. And so it's possible that a baby can have one of these endocrine disorders and not be picked up by the newborn screen. And so you always have to use your clinical judgment. And so if a baby has symptoms of hypothyroidism, you should go ahead and do a real test for hypothyroidism and not be reassured if the baby, for example, had a normal newborn screen. And so this is an important pitfall to keep in mind, that it's a screening program and it's not designed to catch all cases.
All newborns in Iowa are required to have the screening done, but the parent may refuse to have their child screened for any reason. We try to impress the importance of the program to them, because even the most comprehensive physical exam cannot find these disorders. So it's very important to have the screening done. But they do have the right to refuse for any reason to have their child screened. If a child does refuse a screen, then the provider is required to have a refusal screening form completed and signed by the parents, and then that form is submitted to the newborn screening program staff. So after the newborn screening process is complete, any leftover blood spot that is remaining after the testing is done is stored at the State Hygienic Laboratory in Ankeny in a secure, locked facility, and only certain approved staff have access to those specimens. The specimens are stored for 5 years in Iowa, and they're stored for the first year at about 80 degrees below zero. And then the remaining 4 years, they are stored at room temperature. The specimens themselves, the blood spot specimens themselves, are separated from the patient identifying information, and the only link is through a laboratory number that can connect the demographic information from the newborn with that blood spot in particular, but they aren't stored together. At the end of 5 years, those specimens are sent for incineration. And the reason we store the specimens is so that the newborn screening program has access to a fair number of specimens in order to do quality assurance testing, to make sure their equipment is working properly, to make sure that we are able to develop new testing methodologies, and to make sure that we are finding those cases, since they are so rare, that we have enough specimens where we are able to find them and use those positive screening specimens as controls for future newborn screening tests that are done on those babies.
Newborn screening detects infants with treatable conditions where early intervention is key. Newborn screening is a screening tool, not a diagnostic test. Educate parents on newborn screening prior to collecting a newborn screen. Ensure all babies are screened at 24 to 48 hours of life, and samples are shipped out as soon as possible. Follow newborn screening recommendations in a timely manner.
All of the disorders on newborn screening individually are rare diseases, and we do not expect normal providers to be familiar with these conditions. That's my job. However, if you would like to do some more research on these conditions, there are great resources at Baby's First Test, which is a nationally available online resource. The CDC website also has an excellent page on newborn screening. Our own Iowa Department of Public Health has an amazing website, which has a section on newborn screening where you can get additional information. Furthermore, there's a great website called Orphanet with short summaries of many of these conditions.